My name is Prof Eiberg. I'm from Copenhagen. I'm a vascular surgeon, so now you're aware of that. I have this conflict of interest. I'm heading the outpatients clinic at this hospital. It's a big clinic. We do all the vascular stuff, all the vascular ultrasound, as surgeons and specially trained nurses. We have 20 nurses only doing vascular ultrasound. We have 10 rooms equipped with Philips systems. We do 15,000 vascular ultrasound examinations per year. We scan all vessels, but only vessels. And that is, you can see, approximately 600 carotid examinations per year. This is the team, some of the team. So we are a few consultants who can do the most complex stuff. All vascular surgeons and vascular surgical trainees in Denmark has to master basic vascular ultrasound. It's mandatory part of the curriculum. So this is what we're going to talk about today. Approximately 20% of ischemic strokes comes from the carotid. So this is symptomatic carotid stenosis. This is the subject of the talk. But you just need to remember that the majority of the ischemic strokes are not from the carotid arteries. So this is, I was told that this should be very basic, so it is. This is a little bit about the anatomy. There are 3 vessels, the common carotid, the internal and the external. This is bifurcation. So you have stenosis. There's probably lipid rich inside, and there's a fibrous cap, and then you can have a rupture of this fibrous cap, and that would emboli or thrombus would be formed around this rupture, and it would dislodge, and then it could go into the brain and give you an ischemic stroke, of course, on the ipsilateral side of the stenosis. And you can have basically these 3 symptoms. And I'm telling you this because in Copenhagen and in Denmark, we only operate and only treat symptomatic carotid stenosis. We don't treat the asymptomatic carotid stenosis because we don't think it's not good for the patient. And the vast majority of patients in Denmark are operated on. We don't stent. We only stent patients where the open procedure is somehow complicated. You probably all know this. This is a historic randomized controlled trial, or it's patients from a randomized historic controlled trial that has been reanalyzed. This is patient that had their stroke in the 90s, so it's 40 years old. The stroke patients included in this study. And you can see it's on what I'm showing you here is 2 graphs showing moderate and high-grade stenosis, and you can see that the 2 lines are clearly separated, indicating that there's a benefit of being operated on compared to best medical treatment. So we should operate these. This is 2 other groups from the same study. This is the patient with a light-grade stenosis and near occlusions. And you can see there's no clear benefit of operating these patients. So we should not operate them. This is a patient from our OR. You can see that there is a little bit bleeding here because we operate in local anesthesia. So this is from the bleeding here is from the injection needle, and we have put a line here because we have beforehand marked the bifurcation with ultrasound. Then we do the dissection. And here you can see the artery. This is the common, the internal, and the external. You have to believe me when I say this. I think you have to look at it during the procedure before you can be very sure. Normally, I look for the side branch, just to be sure, because I think most necks are a little bit different, and I would say 95% of our procedures is eversion technique, where we cut off the internal and then remove the plaque like this, and then we stitch it on again, and it should look like this, more or less. And you can see this looks a little bit more thin. It is, but it's okay, because the inner part of the vessel is removed. So before we come to this procedure, we have made some kind of imaging and decided that this is a significant stenosis or not. In Copenhagen, we plan and book the patient based only on ultrasound. So, but there are these three methods to give you the diagnosis: the magnetic resonance and CT, digital subtraction arterography, and of course ultrasound. The old-fashioned arterography is per tradition the gold standard, even though we never use it for pure diagnostic purposes. And according to this is from the European Society of Vascular Surgery's guidelines. You can see that the performance of ultrasound is comparable with both CT and MR in most cases. No doubt that the ultrasound of the carotid artery require experienced staff, especially if you're going to take the decision operate or not. And that's why the European Society has recommended that if you rely on ultrasound, then you should do 2 independent examinations of the patient. Most of the patients that we get had the ultrasound local, and then they're referred to us, and we do the ultrasound again and compare, and if we agree, we book the patient for surgery. One of the very good things about ultrasound is that it's very easy to see the proximal limitation of the plaque, because it's where the transducer hit the jawbone. It is the nurses or the sonographer who do this, and if they're in doubt, they call a vascular surgeon. So they are so skilled and experienced, so we believe in their decision is if this is we can operate this patient or not. So you all know this. You can see there is a stenosis here, and we then do a velocity measurement, because we know from high school that there is a correlation between the diameter and the stenosis and the velocity. And see what happens here. At a certain point, the velocity drops. This is made in a laboratory on silicone tubes. In real life, it looks more like this. Not as nice, but you can still see the image. And what is a little bit scary here is that you can see all the outliers here. So it's easier in a lab. This is from another guidelines for vascular surgeons. This is the velocity criteria that most of us use. And what you can see here is that the most important number is a peak systolic velocity of 125. If it's below, we don't operate. If it's higher, we would probably operate the patient. So higher than 125 is corresponding to a significant stenosis, we believe, 50% or higher. Then the next thing you have to find out is the plaque or is the vessel accessible? Can you end the procedure in a secure way? So that's the next thing that we are going to use the ultrasound system for. And then there's this group here, neocclusions or occlusions. We don't consider operating occlusions, and that's often easy to diagnose if you know how to twitch the buttons of the system. The problem is the neocclusions. Neocclusion is a phenomenon that was made for these landmark studies behind these velocity criteria. And actually it was based on the old-fashioned angiogram that we don't use anymore. So you know, it's impossible to refine these neocclusions as the landmark study decided to do. But I'll give you some tips and tricks on that. Carotid neocclusion, that is an occlusion so tight so that the flow is very low, but it's still flowing. With ultrasound, you have a 22% sensitivity, and that's not good. So this is problematic for sure. If you're in doubt, you should at least we do a CT. I have one tip I would give you. I can give you more, but one tip is that distal to the stenosis, if the velocity is very low, it's probably a neocclusion with or without vessel collapse. But this is not, you know, to say if it's a neocclusion or not that's not basic stuff. We believe that we can learn most to do basic carotid ultrasound, meaning is there a significant stenosis or not, in a way so it has to be reconfirmed by a more experienced sonographer. I'm not teaching you now to do ultrasound so you can go home in your own shop and just use ultrasound to decide if this patient should be operated or not. We believe that you should do 200, 300 supervised examinations before you can take that decision. At least that is the demand for our nurses. So, the first thing you have to do is to pick the right transducer. It should be a high frequency, it should be linear array, it should be on carotid preset. You can see that on the screen. We'll play with that later on. And then you should grab the transducer the correct way. This mark should be cranial. It's a good idea to put your elbow in a resting position. Don't scan like this. And remember that all carotid ultrasound is easy on these patients. You're going to be surprised when you come home and you have a very diseased artery. This is Camilla from our outpatient clinic, and you can see she starts the examination by positioning the patient. Very important if you have to survive doing vascular ultrasound for many years. And I have decided to take, real pictures from the outpatient clinic and not this perfect, ideal pictures from the system or textbook. So you can position the patient two ways. I always do like this. The majority of our nurses do like this. But I don't want to move around of anything in my outpatient clinic because, then I have carotid patient, then I have lower limb, then I have aortic, and then I have to move the bed all the time. So you can do both. It's up to you. And here we are clearly going to do, or we could maybe put the models the other way around. There are several transducer positions, and it is the relation to the sternocleidomastoid muscle. If you're in front of it, posterior to it, or just directly on it. There's no position that is right or wrong. You just need to know that all patients are different, so you should be able to go wherever you get the best picture. A good thing is to keep this line, because then you'll hit the jawbone. If you go up here, you can actually scan the carotid. You can get an image of the carotid image artery too high in a position where you'll never be able to make a secure operation without luxating the jawbone. And you cannot do that in local anesthesia. So first, you put in the patient ID somehow. Then you optimize the B-mode image. Gain, depth, focus. I'm not showing it here. We're going to work on that on the stations. Then you get an overview of the vessels in a transverse view, B-mode. And you go caudal to cranial. Special focus on the location of the bifurcation. Is it high? Is it low? Sometimes the bifurcation is very low, making it difficult. Sometimes it's up under the jawbone. It's good to have this impression of the basic anatomy before you start the important stuff. So here you can see the carotid artery, you can see the vein. This is a poor image I have to steal somewhere. So here we can see the internal and the external, and the vein and the muscle. I think this is a small image, a small movie where I start here, just over the clavicle. So from the, and here you can see this bifurcation, and you have two arteries here. So you need to do that for the first, as the first thing. And then we have this. This is the longitudinal view. I think it's more interesting to focus on the bifurcation here. The difficult thing is to be sure if this is the internal or the external. Look for plaques and tortuosity. Let's see. So here's one artery, and here's another one. I would say that based on this, I'm unable to say if it's the internal or the external. So I have to turn on the color to do that. This is one of the tricks to look at the two arteries. So you should keep this point of the transducer stable and then turn it like the arms on a clock, and then find one and find another one. So this is on the common carotid, and then you do like this. Then I turn on the color, and I look at the lumen first of the common carotid, and then I have a vessel here, and I have another vessel here. Here there's clearly disease. Here there's clearly not that much disease. I can tell you this is the external and this is the internal carotid artery. Look for velocity increase, like this picture here. Look for a filling defect, color filling defect in the lumen. And this is my friend. I like to find the side branches, because then I'm sure that this is the external. I continue with color. I do a velocity measurements of the common carotid. Then we look at the external, where we saw the side branch before. And then just to be sure, you can see Camilla, the nurse, is hitting the temporal bone and see this tapping. Then we're sure that this is the external. And here you're in the stenosis that we saw before, and you can see turbulence and a strange pattern of the flow. And you can see that this is a low resistant flow. There's a lot of blood running into the brain in the diastole. Otherwise, you would faint every 6 times in a minute. And here you can see this is a high resistant flow, because there's very little blood flowing cranial in the diastole, because this is not a brain signal. This is supplying the muscles and the skin, the face. So this is another way to decide if this is the internal and the external. So you need to look for side branches, you need to look for tapping, and the flow curve. Most often, but not always, the diameter of the external is smaller than the internal. So the internal is has most often the largest diameter. But when you have a vessel like this, everything is difficult. This is the one you saw before. So now we make our Doppler curve velocity measurements. Here is the internal carotid artery. And you can see I have a velocity of more than 300 centimeters per second. Then you just go to your table. It's more than 230, so it's it's a high-grade stenosis. This is for sure not a near occlusion with a signal like this. This is cranial to the stenosis, or peripheral to the closer to the brain compared to the plaque that we see here. So you can see I'm going deeper into the patient, and here I check the velocity, and you can see it is actually normal. So I believe that we have a distal limitation here, so this patient can go for surgery. And you can see if this were lower than 50, I would be a little concerned if it was a near occlusion. Then I would check the other side and compare it. This is the distal extension. You can see I cannot get higher with my transducer here. I hit the jawbone. This means I cannot, with my hands, get higher. So this is where I would decide if I can operate or not. So this, where Camilla has her thumb, corresponds to this area. So if I can, now this is not a good image, this is real life, but you can see that here I have a normal velocity. I didn't put on the measure, but actually during the procedure, open surgery, I would be able to go here, because this is where I hit the jawbone. So I think it's a very practical and non-academic way to decide if you can put on your clamp or not. I don't know if I can make this work. This is just the only way to learn this is to train. This is the Red Bull Formula 1 racing team changing 4 tires in less than 2 seconds. So this is what we want you to do. So train, and then train. That's it. If you don't know where Copenhagen is, it's here. And this is a drone. This is the view from my office, from to one side and for the other side. This is a power plant. It is they are using waste to make energy to Copenhagen, and this is a ski slope. A ski slope, so you can ski in the summer here. You should come to Copenhagen. So now maybe you have questions. Otherwise, we'll take them at the stations. You are a little bit too many for 3 stations, but that's how it is. We have half an hour-ish to train, so we should rotate. I think I have someone who can help me taking care of the systems. So Now you have to stand up, and we need to have the patients lying down. Before we start, we should actually, optimize the image. You are happy?
Okay.
It's a good system, so it's
a little bit grainy.
So the depth you could work with. I think it was good. I didn't, and then we just have to do it. So I'm sure you learn. Yeah, okay, exactly. Then you can adjust the gain. I know you want to push the corner, but just keep it B mode, and then go to the wait a moment. Try to go to cranial. Show us the bifurcation. You can see the bulb. Perfect. And then try to, keep one end of the transducer, and then turn it like this. See if it gives sense for you. 100 patients, you can see both arteries like in the textbook. Normally, you never see it. And this is the vertebra, of course.
Yeah.
Cool. Now we can put on the color. And this is the yes. Let's see.
Yes.
And if you want it to be, it did it itself. It's a very good system. It has this new feature, so we have this 3D impression of the flow.
Looks like a cartoon.
Yes. So before you start that, I think you should in the color see if you can see
any plaque.
Yes, plaques, side branches. Yes. Yes. Sometimes I turn this around. I think there's no.
This is external.
Probably, but I would like to see a side branch. I never decide beforehand if which one is the right one. I need to see a side branch. I need to see the flow curve.
How do you do it in transversal? Or?
No, never. There's a steering button here, so you can do it like this. My experience is that sometimes, when I do lower limb, I have it like this. But when I come to the bifurcation, I like to have it a little bit more perpendicular to the flow.
Okay.
It's not a problem in this image, the 60 degree.
Okay.
If you go very parallel, then you simply lose some of the contrast in the image. But these
difficulties to see a side branch actually.
You cannot see them. No, I agree. Should we try to see the color if the flow curve? Maybe that would help. It's a little bit suspicious that you have this. If it should go to the brain,
Okay.
that could be, but look at the other one.
Wait a second.
Here.
Okay.
Yes. This is a brain signal. Agree?
Yes.
So let's try to find the other one you showed us before. Yes. So then I would, then you should mark the image. Exactly. And that's it. You should mark an image where you have this tapping. If you are...
The measurements are done automatically? Or?
I never do recordings in the external.
No,
I don't,
but in general you rely on what it shows, like the...
Then I would go and measure, but I will do that in where I need it.
Okay.
But it's not very relevant here.
Okay.
And then I will save this. Poof. Oh, we cannot do it because it's...
You will see the bifurcation when you will see two.
We just pretend it's a patient.
But the most important parameter is the maximum velocity.
In the internal. In the external, the only reason why you're interested in the external is to be sure that it is not the internal.
Okay.
Yes. There is an option on these systems so that you can have
All together.
you can have simult, but so this is the internal, external.
Internal.
Exactly, because you have this. I'll turn it down a little bit, otherwise. Good. Yes. And then I agree. Then you can go into longitudinal. Very nice. So we just cheat and put on the. I would adjust the steer a little bit in this direction, and then it's just for learning purposes, it's good to just look at this. You can see this is a mixed signal. It's both running to the brain and to the face, because it's a common. It's a good idea to put your hand on the patient like this, because then when you do something, it's much easier not to move your hand around.
Okay, so it's fine.
So you should put your hand on this, if you can, on the shoulder, and then relax. You see these possibilities here. You can choose if you want to prioritize the image or the curve. And there's this one. I always use max view now. Okay, move towards the head. Okay, something is happening here. A little bit higher. Stop. And here, now you need to turn it like the arms on a clock a little bit. You have to, exactly, and see if you can identify one. That's too much. Just 3 to 5 degrees, and then you should, in one image, you should try to visualize the internal, and another image, the external. It's not easy. This is a cross-sectional. It's too much. Exactly, you have something going down here, and you have maybe something here. I'm not satisfied with the angle. This is better. What do you think? Is this to the brain or to the skin?
Brain.
Brain, I agree. So now this is the internal. Try to find the external. And this is small rotations. And small, but it's in your fingers. Something's going on here. Try to follow this one to make it. Try not to push too hard. It's not that nice for the patient. So you should try to make this a tube. I think this is probably the external in a kind of cross-sectional view. Should we check it? I know it's not. Let's see. You see, this is impossible if it was for the brain. You have a kind of reverse flow. So this is, and if you're in doubt, I'm touching you now. Let's see, it should be here. Maybe here. I think this is tapping. You're not. The position is not optimal. But that is a trick. You find the temporal bone, and then if you're in doubt, you should palpate the pulsation of the temporal artery, and if you hit that, you push blood back into the external, and you can see that on the flow curve. I think you should. Let's change around so we can give another colleague a chance.
Yes.
Can you talk a little bit about vertebral arteries?
Vertebral artery is there's a big fuss about that. Vertebral artery. I think it's funny to scan. I like to scan it, but I never use it, so we've stopped.
Just like for still syndrome.
How many patients with? I think I've seen 2. I think we've treated 2 in 30 years. So for a stroke patient, it doesn't give sense. Look at the vertebral artery and see if the flow is running towards the brain or the wrong direction. But we have stopped because I don't think it has any consequences. We very seldom treat vertebral artery. Very good. I help you. Okay. So that was the common. Yes. And now you found the bifurcation. Yes. You are fast.
Which is, I would say, logical according to normally we know that.
And you see, you are not resting your arm, are you? Okay.
Okay. So this is what it's moving in that direction from near field to far field. Okay.
36.
You have impression that there's something here and something here?
Because that's what usually we like to see the artery in
Yes, there's one.
so it depends on how you want
And can you find the other one?
all the transducers.
Oh, this is internal.
Maybe. I'll give you a little bit more gain.
No, I'm sorry.
Let me, I can help you. Color.
Yes.
And then we should we look how this looks like? Adjusting a little bit here.
So that's why usually we have this kind of auto inversion just to be
You are right.
after we will
This is probably the
veins will be
internal. Agree? Can you find the external without moving too much? Ah, it's up. Exactly. Yes. You can see all the blood running to the brain in the diastole. Not much blood running to the brain in diastole. Good. Should we see if we could do the tapping? Yes, it's difficult. You lose it. If you can find it again. I think if you can get a more longitudinal view, even better. Keep on. Small movements. Yes. You see the side branch?
Yes.
Measures peak systolic velocity and save an image of the common carotid with a curve, flow curve.
Okay.
And then you do the same in the external. You don't need to save any. You don't need to make any measurements. You just need to show on the image that you say that this is external before you, because you can see the tapping or you can see a side branch, and you label it external. And then you go to the internal, and you find the highest velocity, and save that, measure that, and then you go proximal,
If it's possible.
and see if you can get a normal velocity. Yes.
What about the angle of the box?
The angle, you can do whatever you like here.
Yes.
Actually, I like to have
But
it.
the better way to study, what is it?
I like this. You know, some of the if it's a complex case, sometimes it's easier actually to have it like this, because when you go to this part, but you know, there's no rule. You should do whatever because all patients are different. Maybe you have a little bit too much. I don't know. Like this.
Okay.
Very nice. You see, this is seldom to see everything in one image. See if you can find a side branch somewhere, then we're happy, and then you have to have it in the center stream, this cross. You can push. I always use this shortcut up here.
Okay.
Agree.
External.
Yes, and here, you know, here's put your auto measurements on external. So I would save it and write ECA forward. Exactly. This is the important one. And in a case like this, you need a steady hand. Then I do what I call walk the Doppler. It's a quick way to see if there is any velocity increases here. I'm looking at the curve and on this at the same time. So
Does it work
low
also-
velocities all the way.
It works also outside of the box.
Yes, this is the yes. You can do the measurements where you like, and then of course you should you know, do something like this and write no, measure proximal. I see, something like this. Save. If you look at this, this has to be cranial
Yes.
or to the patient's right,
Okay.
like this
Both. Yeah.
or this.
Okay.
And then put your arm on the shoulder. I remove the collar and I remove this, and then you get close to where the neck starts. More you have to exactly, and see what's going on here. So you have something here and something here. You need to put this into the center of the image. So you have to yes, more. Even look at the screen. And from now on, you're not allowed to look at the patient, only look at the screen. I'll tell you if you start looking at the patient.
Okay.
So you compress the vein,
Yeah.
okay? And then you don't need to compress it anymore. Then now you're sure this is the muscle. And then you follow this in transverse image. The first thing you should do is to optimize the setting. That's the good or bad thing about new systems. You know, that they think for you, so they start in good settings. So and then you follow this. Keep it in the center. Good. You can see what's happened here.
Yeah.
Yes.
Okay.
Good. Go back.
Back. Okay.
Go back to where the neck starts. You see, this is a gel problem.
Okay.
You are lacking contact, but let's just focus. Now you turn longitudinal. No, the other way around. No, you're right. Sorry.
Okay.
Yes.
Like this.
Yes. So you have the vertebra here. Yeah. Common carotid. And try to go from one. Don't look at the patient.
Yep.
Look at the screen. Go from one side to another side. Small movements. Yes. Here you have one vessel, I guess. And then you have another. And you have another one up here.
Yes.
That's not difficult. Then put on the collar. You need to make one of them red. I think you're sliding off. You're allowed to look at the neck now. Get back on the track. Yes. Good. You know, you should not always believe on the collar, because actually you could have pushed some buttons so it was reversed.
Yes.
But when you look at this, what's running towards the skin is going to be blue, and what's running away from the transducer is going to be red.
Okay.
So I would suspect that a vessel feeding the brain is running more away from the transducer than towards the transducer, and so I think this is a vein because it's running more towards. So you need to find a red one.
Okay.
Yes. Focus on that. Get it into the center. No. Yes. Keep it. Keep it. Perfect.
Okay.
And then get a little bit more cranial.
Cranial.
Yes. And look at the screen. Don't lose it. I give you a little bit more power here. So we have the experience that you try to make very slow movements with your hand. You have one artery here. No, you make two. It should only be in your fingers.
Yeah.
That's why you should rest your wrist at the shoulder.
Yeah, I forgot to rest.
Yeah. Small movements. Otherwise, we will get dizzy here behind. You have one here. And you have the impression that you have another one here.
Yeah.
This is a bifurcation. This is a flow split. Very good. So let's focus on this one. Stop. Have a steady hand. I'll help you with the buttons. I put on the Doppler curve. I'm not quite satisfied with the angle here, so I use the steering. That's better. Yes. Perfect. And then can you move the transducer a little bit towards the head? Yes. Nice. Stop. You can see all this blood is running towards into the brain in the diastole, so it's the internal.
Okay. Yeah.
Then you could start looking for side branches, tapping, just to be sure. So here, this is the internal.
Yep.
Then you would need to do some measurements. Now you can relax in your hand. And you can also, if you want to do both. So now I have two measurements. It's up here. So this is 60 centimeters per second. That is far below 125.
Yes.
So there's no stenosis. Okay. So I would, if we have to do it as in textbook, you just do it in this plain B mode. Now you're cheating, showing us the subclavian. So the vein, just compress it. Exactly. I think in general you should not. You do the compression of the vein just to be sure that you are in the right place, but it's not very nice for the patient to be compressed. So I think it's a good guide not to compress too much. It should be open. If you're in trouble, it's because you lack gel. Very nice. Was that a side branch? No. My rule of thumb is that it should be 1/3 of the diameter of the vessel, approximately. So I think this is too big. I think maybe even smaller. Yes, I think that is probably you can have one here
So
and
it's
one
more
here.
accurate when it's
1/3. The middle 1/3.
Okay.
Because if you make it too wide, it may camouflage the peak systolic velocities that you're going to measure.
Okay.
I give you a little bit more power here. Now I have to turn down the volume otherwise. So how much gain should you give it? I give it, and normally I go like this, too much, and then I turn it down until I have a few artifacts like this. Sometimes when I do the workshops at the Society of Vascular Surgery, sometimes we have real patients, but it's painful because they are 80 years old, they're confused, they are diabetic, and they faint, and they forget the medicine. And there is this button. You can try. This is yes. Try to push it. It helps you to optimize.
One in my hospital, and
yes.
they don't. Do they have it? Because I don't use it.
No, it's many years ago I used Siemens. I think I'm sure they have it.